line.
Watch anything, just in case you missed it. I'd ask you to put your microphone on mute when you're not speaking once we get started. And to take advantage of the interactions available in the chat window, if any of you are familiar with Zoom, there are some nice bells and whistles that you can use to communicate and begin asking questions as early as now that we can field as soon as Heidi's done with her presentation. So with that being said, I will turn it over to our featured presenter, Heidi Truschel. Heidi's a health risk communications professional with experience in pandemics, regulatory actions, and declared states of emergency. CDC and FEMA trained and exercised. She is skilled in crisis messaging, managing breaking news, and developing and releasing emergency information across multiple platforms. Heidi has expertise in converting complex ideas into effective messages for stakeholders, including epidemiology investigations, laboratory results, quarantine actions, regulations, and emergency management. And it is my pleasure to turn it over to Heidi. Thanks, Heidi.
Hi, thank you very much for joining me today. I know that this is probably one of the most hectic times that we've ever experienced. A lot of uncertainty, and certainly the current situation with COVID-19 has impacted every workplace and every person. So today I wanted to talk a little bit about the framework for how public health works. I am a public relations and communications professional like you are. I spent some time in news reporting, newspapers specifically, and I'm able to talk a little bit about the framework in which I worked, and then how it informs a communication crisis strategy, and maybe a few starter points if you haven't begun to do a crisis communications plan. And I'm very happy to answer any questions as we move on. So my experience was 15 years as the Public Information Officer, Chief of Public Affairs for the Delaware State Health Department. I can't necessarily get real specific about exact New York State procedure, but during the time that I worked in public health, we were following a national framework. So to start out with, a lot of people are trying to understand what the difference is between public health and healthcare. What is public health other than the community hospital? And it is its own discipline. So medicine, healthcare, doctors' offices focus on the unique needs of individual patients. You've seen that in your own doctor and healthcare provider relationship, that they assess you as a person, your unique risk factors, your unique wellness factors, and they will treat your conditions. Public health is its own both academic discipline and profession, and it focuses on looking at data and systems that impact whole populations. The trademark event that public health is defined by is the implementation of clean drinking water through public drinking water systems. That was sort of the landmark event in which the first real public health physician began to affect the health of a lot of people at once through intervening on a systems level, which was assuring the cleanliness of a public well. That person was Dr. Snow in Britain. And public health practitioners can come from medicine, but they can also be chemists, they can be engineers, they can be nurses, veterinarians, pharmacists. They come from all branches of science, healthcare, social work. And just to clarify, what is the role of an engineer? The best example is the public drinking water system, that there are public health engineers that design those systems, design the purification and piping systems, and the way that we monitor the amount of chlorine and other purifying chemicals that go into our water. So there's a lot of professions that make contributions. Epidemiologists are sort of the quintessential public health professional because they specialize in the study of outbreaks and disease patterns. You may have been seeing and hearing from epidemiologists on news broadcasts or reading quotes of them in publications. And their primary jumping point for dealing with outbreaks is that they have a strong basis in statistics. And you've probably seen the press conferences showing disease modeling. That is the epidemiologist's specialty, is projecting and disease modeling and finding common factors across an entire population for a health problem. Epidemiologists don't just deal in transmissible disease. There are epidemiologists that work on cancer. There are epidemiologists that work on tuberculosis, which is transmissible. They also work on injury prevention. So epidemiologists are a big part of what makes public health strategy unique. The other thing that epidemiologists do is they conduct disease tracking and investigations. And each state has a reportable disease law. There are a variety of public health laws. The reportable disease law is one. And for most states, they have a similar list of mandatory reportable diseases, and it's usually over 100 diseases that health professionals are required to report to the local and or public and or state health department when they diagnose these diseases. And examples of that 100 diseases, I've put a few there: influenza, cancer, tuberculosis, but also rabies. Rabies is tracked in animals in order to prevent it in humans. E. coli, which can occur through food sources, is tracked in order to systematically address the contaminated food source. Sexually transmitted diseases. But some people are really surprised to find out that there's tropical diseases that don't typically occur in the US on their state's reportable disease list. So malaria and leprosy are on most states' reportable disease lists. Also a few others like dengue fever, yellow fever, and Ebola. The reason for that is that we want to maintain the rarity or absence of those diseases in our state. So the first case that we hear about of leprosy in a state or a county will be investigated quite thoroughly. Each of those diseases, each of those 100 to 150, has case criteria, so that there is not one number of cases that constitutes an outbreak for all of those 100, 150 diseases. Each disease has its own number of cases that constitutes an outbreak. Also, the definition of what is a case can be very specific. For example, anthrax was defined by CDC as requiring a fever of over 102 degrees. And if you had a fever of 101, you might not be considered a case despite your laboratory tests. So when you read about communicable diseases, when you hear these briefings and press conferences on COVID, these details are taken into account. And we are hearing so much about the need for testing for COVID to be certain that is what individuals have. And so that is part of the process for so many diseases that are tracked. Also, because of this reporting system, which has existed for decades, we know what is a typical number of cases year to year. So for example, in the state of Delaware, 10 or fewer cases of measles was considered normal. And once it got into the teens, it was considered an outbreak because that was above normal for that particular disease. Outbreak or epidemic is considered that change beyond the disease's normal level. So in other words, using the measles example, 8 cases of measles in that state would never be called an outbreak. They would be called occurrences or cases. The use of the word outbreak or epidemic is a specific declaration that has a technical meaning. It requires that a new level be achieved, or that a disease is now occurring in a new location it hasn't occurred in before. We've had that happen with a number of other diseases in the last 15 years. West Nile virus was never known in the United States prior to the 2000s. Zika virus was not known in the US prior to the last 20 years. And 30 years ago, Lyme disease was not known to be common. So those were all instances when a new level was achieved in cases and it reached an outbreak. Because smallpox does not exist in the wild, is how it's often stated. It's not existing in any part of the world other than 2 laboratories, a US government laboratory and one in Russia. Any case of smallpox that occurs in any population worldwide would be a deviation of normal, and one case would then be considered a pandemic because it is so far exceeding a normal level. And I hope that I did an all right job in clarifying the very specific use of those words, because with today's press conferences, that is the sense in which leaders and representatives of the CDC are speaking, is with those definitions in mind. So pandemic has a very specific meaning also, and a local health department cannot declare something a pandemic. Only the World Health Organization can do this. And I think there were questions 2 and 3 months ago about whether COVID was a pandemic, and without the World Health Organization having declared it, the answer that most people were giving in January and February was no, it's not a pandemic, because that is a highly technical word. And it reflects the nature of much more global spread of the disease. In some cases, it reflects that the disease is now occurring on multiple continents. So I wanted to clarify what pandemic means in these circumstances as well. The agencies that respond to these issues of disease occurrence can include your county health department, state health department, and the federal government. So I think one thing that's kind of absent from the understanding of public health in these briefings is that every day of the year, a county health department is investigating the occurrence of some kind of reportable disease. The most typical could be that your county health department is engaged in tracking a foodborne illness from a restaurant. Public health departments tend to be known for their restaurant inspections and other kinds of inspections. The county health departments may also be engaged in tracking HIV, other STDs, and certainly the illnesses that school vaccinations intend to prevent. So measles, mumps, and rubella. Those would all be things that county health departments would be watching for, and if those reportable diseases came across their radar, they would be asking about where did you dine, who did you have contact with, who's in the classroom with the student. So disease investigation is an everyday occurrence. It doesn't just happen for situations that make headlines. The state health department does the same thing. There are a handful of states in the country that do not have county level health departments. They feel that they can manage the entire state from the state level and operate local bureaus to reach the population. Delaware was a state that did not have a county health department. It managed all 3 of its counties from the state level. The health department also operated a laboratory that did all of the communicable disease verification testing and became capable of conducting bioterrorism testing as well. They had the extreme chain of custody precautionary lab that could control exposure and do extremely dangerous testing in a confined, controlled space. It's worth noting that health departments ultimately report to elected officials. So while the director or manager of a health department may be a health professional, an epidemiologist, someone with a degree in healthcare management, they ultimately report to the elected official who is the highest ranking in that county or state. So the findings of a health department get reported to that elected official's office for the decision on how to act. Certainly those health departments advise those elected officials, but there is a chain in which they report. So when we look at what's happening right now with COVID and with some previous outbreaks like the H1N1 swine flu 10 years ago, what we tend to see is that they are acting on a set of laws and health powers that are conferred on them. And the history of some of this goes back to September 11th, 2001. Immediately following the World Trade Center disaster, there was an outbreak of anthrax that was distributed through the mail. And some of the first cases were at the National Enquirer headquarters in Florida. And there were other cases that followed. And this prompted a lot of prioritization for preparing health departments to respond to things that weren't foreseen. And what happened were states were advised by the federal government to look at what legal powers they had to respond and to revise them as necessary or possibly enlarge those powers. And those powers are some of what we've seen utilized in the last month. Those powers include conferring mandatory quarantine and isolation, the power to designate essential employees who can be active even though the general public is not active. They can mandate closures. They can take possession of essential equipment and supplies. And there's a number of other provisions under health powers legislation. Following that, the CDC in the early 2000s provided multi-million-dollar grants to health departments to actually plan for these situations and to hire staff, conduct additional training, and run through practice exercises. And those practice exercises could range from a group gathered around a table saying, this is the first thing that we find out about, who does something next, to an actual gathering of people with the equipment and with volunteers acting as patients, to then see how patients would move through a mobile hospital or through a vaccination clinic for emergency vaccination, or how they would process the public in providing prescription medications for them during extreme disease outbreaks. In order to make these kinds of responses happen, risk communication becomes a high priority, and that's exactly what's happening at these press conferences that we're seeing daily. The Center for Disease Control is the federal health department, and they developed training programs and identified key principles that I thought I would share with you today to keep in mind and to possibly simplify your risk communication planning. And under the CDC, they boil it down to 3 priorities. One is to be first, the other is to be right, and the third is to be credible. And I'll speak briefly on these, and I'm sure many of you have received some training and are familiar with this. But the concern about being first is to get ahead of the rumors. And we've certainly seen how various rumors emerge in our current situation and how they play out. And to be first and provide the proper message, which is the second principle of being right, is meant to help the public adapt and make decisions and protect themselves as quickly as possible. The second category, be right, is one that I found is an ongoing challenge because of the speed of information developing. We certainly see it now as individuals watching the news coverage and the press conferences, but within the offices that are seeking out the information on cases and running the laboratory tests and moving the equipment, the reports internally move so rapidly that it is hard to constantly confirm what the correct answer is, the correct data. And so one of the most important things to do in advance is to identify the chain of information release. Who verifies the information before it goes public? Who gets information to the spokesperson? Is the spokesperson the person who delivers it? Is there someone who's conducting risk communications that prepares multiple spokespeople and coordinates their messaging? These are all part of the information verification process in order to assure that when we advise the public, we're advising them correctly. Once information is out, as I'm sure all of us in public relations know too well, it is very hard to rein it in and correct it. The last category, be credible, is, I think, such a central part of public relations that we live that message every day. And the one thing I want to mention from my crisis communication experience is that part of being credible is not over reassuring. There have been different approaches to trying to deliver a press conference. And one approach that I think we have to be cautious about is being overly lighthearted, overly cheerful and unconcerned. In a crisis like we're experiencing now, to be serious is to be appropriate. When it comes to communications plans, there's definitely some key things to keep in mind as you develop a crisis plan that would work in your own industry sector. And one of the valuable tools is creating policies, because policies create a common understanding of how everyone will work when these kinds of situations emerge. It's easy to feel in a workplace like, because so much of the world has changed, whether it be the presence of the illness or the fact that we're now social distancing or that there's equipment shortages, often employees will feel like all the rules are out the window. And policies that address crisis communications can help keep people on track when it seems like the world has changed. And those policies can outline a few of the things that I've just mentioned. Roles of who verifies information, who develops the final version of that information for the public, and who delivers that information. Who is the person that will speak at the press conference? Who is their backup if they're detained or if they themselves are ill? There are some valuable policies that address the approval process and the time frames for turning around information. Some organizations have a required time frame of a public briefing every day at a certain time, and that's in policy. And that helps everyone who is on that response team understand what they're driving for, what point in the day they have to finalize and verify. One of the ways that you can start to come to grips with crisis planning, regardless of industry, is to work on hypotheticals and thought experiments. When I first started working on crisis planning, I was somewhat of the school of thought that you can't possibly identify what kind of crisis will occur. But I came to understand that every organization that has been around for enough time has either seen a crisis in their industry or has lived through one or two of them. And that can become the beginning point for considering policies and practices. A sort of universal crisis that you could use to start experimenting with a crisis communication plan is a data breach, because in this day and age, a data breach is a crisis across just about every industry. And you work the planning by thinking of how you would first become aware of that problem, who that problem would then need to be moved to in your organization for it to be addressed, and you would work through all the other handoffs and roles. For public health, every disease that occurs is a practice situation for risk communication. In my time working, we had a number of tuberculosis outbreaks in large workplaces that ended up becoming a crisis for an entire town. And we learned from those situations if our handoffs were working and if our policies were adequate. We also had a Legionnaire's outbreak that was tracked within one part of our agency, but had never been included in briefings to other parts of the agency. And it actually became known to us after a news reporter elevated it. So that was a case in which we discovered that some handoffs weren't happening. And then the H1N1 swine flu outbreak, actually one of the first states to have it was the state of Delaware. It was being transmitted at the university, and thankfully the cases did not have severe health consequences for the people who contracted swine flu, but it did put us into our emergency operations plan, and we were conducting press conferences and emergency clinics to vaccinate people for influenza. So some of those processes were tried. And you may be able to look at your own workplace and think back to some situations where a process worked well and you want to build from that. Risk communications is really, in my experience, always interdisciplinary and always interdepartmental. If you work at a large organization like a university or a hospital or a very large employer of hundreds of people, ultimately there will be multiple departments that play roles that have people affected, and those will all become parts of the communications response. Another a very important consideration is right to know for the public and balancing it with legalities for your industry. Public health defines itself as a sentinel agency that warns people for the purpose of helping them protect themselves and for the public health agency to take protective actions. Part of the goal of disease tracking and epidemic identification is to, as we've seen with COVID, find it at its earliest stages and take measures to prevent it from becoming bigger. So advancing those findings from disease investigations, putting them out there is an important priority. But in the health setting, HIPAA and confidentiality are a major part of how we are allowed to work. We cannot reveal identities of people who are affected by illness or information that in a combination can lead to identifying someone. So what you may notice with some of the COVID briefings is that they will talk about disease occurrence in a part of a county or in the county as a whole, particularly in the early stages, because one or two people being identified as having an illness with certain symptoms can lead to their identification. It's only when there are so many cases that people essentially become anonymous in their diagnosis that a county might reveal statistics per city and so on. We know that Governor Cuomo has talked about his brother having COVID. I believe his brother revealed that first and made his own decision to disclose. And once that became public, it is now discussed. But it is the patient's right to maintain their confidentiality. And so in writing a press release where you are bound to confidentiality, you will often be just simply talking about age ranges rather than saying that this person of this town with this age has this illness and is hospitalized. That combination can be problematic in certain circumstances. So it's a real challenge when fulfilling that right to know. The Freedom of Information Act also compels any organization that's tax funded to make their documents public with a number of exceptions. So for health organizations, if the investigation into the disease occurrence is still ongoing, it is not public until that investigation is closed. If the document is a draft, it is not releasable. And also information that impacts security is not releasable. And so when emergency management plans in the public health arena or for a county organization include information on vulnerabilities, those sections of the plans are not subject to Freedom of Information Act. So you will see these different legalities balanced, and I also bring them up because I'm sure there's legalities that would impact you in whatever work setting you are in. And those, you know, may not block being able to fulfill public's right to know. They just may change how you work on it. I'd like to kind of start to wrap up by saying that when I look back, the essentials that I recall for communications response really includes the earliest possible internal reports of a situation occurring. And so there had been a number of circumstances where we discussed with our frontline staff which kinds of circumstances we wanted to hear about quickly. Sometimes staff would think that a certain situation would just be routine, and we would have to redefine what we thought concerning information would be that needed to be moved up. And that may be a kind of conversation that would help other organizations in their crisis communications planning. An ongoing challenge that I touched on is official and unofficial workplace information. Who is the employee in your organization who would have the best handle on the final data about a situation? Who can give you the most accurate count of your employees should there be a fire at your workplace? One of the examples that I very much recall is that I needed to get a disease count in order to respond to a reporter. And I was directed to a person on staff that I didn't usually get that kind of data from. And the number that I ultimately received and then provided to the press was not accurate. It turned out that that person didn't know that they needed to get me verified case counts. They gave me a number for their unofficial working case count of all the reports that they had started to investigate. So their unfamiliarity with our usual criteria resulted in an inaccurate number. And that is the reason that I recall how very important it is to know who provides your official numbers versus someone who may have a less official scope and understanding. Approvals can take time, but they are very much needed as part of that verification process. Over time, the approval system that I worked in was refined and some of the kinks were taken out of the process. At one point, we had a number of approvers who each came from a different discipline and were reviewing information in order to assure accuracy from that particular point of view, but they were all reviewing it at the same time. And ultimately what happened was they were going into documents and editing each other's changes out of the document. And so approvals really need to be linear. It needs to be one handoff after the other so that the guidance of one person is not undone by another unless they have the authority to do that. Ultimately, when the clock is ticking, you also need to know who's the final approver and what circumstances are that you can go directly to them when you just do not have the opportunity to have the multiple eyes go through it. And finally, who assures message consistency in an organization? Most organizations have a website, may issue a press releases on emerging situations, also maintain Facebook, maybe putting out fact sheets, maybe sharing a professional protocol sheet, whether it's for teachers or physicians or social workers, and who is looking at all of that to make sure it doesn't contradict each other. Ultimately, that can be the role of a chief of communications or public relations director, but that needs to be identified. In some cases, you have a separate webmaster and another person who's writing a press release. And are they using the same data and repeating facts in the same light? Those are some really key considerations that prevent problems which are so hard to correct. And, you know, as I'm talking about release of information and accuracy, I wanted to touch on something that was emphasized greatly by the Centers for Disease Control and Prevention in their risk communication training. And that is that CDC did not define panic as any heightened response. CDC said that panic is self-defeating behavior. It's people doing things that will lead to greater harm rather than to reduce harm. And so we were advised that we should not refer to behaviors like obtaining supplies or increasing sanitation and infection control measures. Wearing masks would be one of them. That we don't characterize that as panic, because ultimately, if you wear a mask, whether there's illness or not, it's not harmful to you. It's a thought out process. And so sometimes I think the public does get portrayed as not being rational when that may be an overstatement. One of the risk communication principles that we were taught is that we don't try to manage the public's emotions when we release health information, that we trust them to be able to take actions to their own benefit if we give them the facts. And sometimes in organizations, the discussion about whether information is upsetting is given greater priority than whether the information is released on time. The goal of risk communication is to help people handle difficult news. And as every public relations professional knows, the keys to that are showing respect, but also showing caring. That we do not over reassure and promise that there won't be problems, that we have to acknowledge uncertainty and stay poised without attempting to role model cheerfulness or another emotion other than being factual. That applies mostly for public health. It may not be quite so strict for another industry, but I think that's a foolproof way to approach it. And lastly, I want to mention that executives and executives that become spokespeople often don't understand journalism practices as well as they may think. And I've found that providing a rules of the road kind of training for people that don't normally speak to journalists usually corrects some misunderstandings about how to handle an interview. I've talked to a number of subject matter experts who had the impression that they could do a lot more with off the record comments or providing a document strictly on background, and have found out, unfortunately, that those documents get posted on websites and that they get quoted for those comments. So advanced training, even for those who think they may not benefit from it, is beneficial. And I'm happy to take questions or provide additional explanation if anyone has a question at this time.
Thanks, Heidi. Anyone have any questions? I thought that was a really nice explanation, kind of a brief background and some of the terminology that's kind of taken us to where we are right now in our world. Many of the same principles and ideas kind of correlate with whatever industry we're in, but certainly in the environment that we find ourselves in today. So we appreciate that. Anyone have any questions for Heidi? No? Thanks, Bob. Bob says very thorough and detailed. We appreciate that.
Thank you.
No questions. I guess it was thorough.
Well, I hope that it's useful to folks, and I'm sure many of us have had risk communication training. There are some things that just rise to the top of my mind that have occurred over and over and over again.
Oh, we have a question from Bob, Heidi. Let's see, would local health authorities be open to volunteers from the PR community?
They may be. During emergency preparedness planning in the early 2000s, there was an effort to create a sort of a directory and registry of professional people that would be able to contribute to an emergency response. And, you know, typically that, of course, was focused on physicians and nurses and even pharmacists, but really every profession was valued. And certainly in these outbreak situations, most of these agencies are working 24-hour shifts. And what happens after, as you can imagine, 2 weeks to a month, people are exhausted and they do need relief. So you could certainly approach your local agency.
Great, thank you. Catherine, wondering if this will be available via recording. Yes, we are recording this and we'll make it available afterwards. So thanks for that question. Anything else?
Does anyone want to share where they might be at in crisis planning for their workplace? It's a big undertaking, so it's
not
hard.
At 4 o'clock on a Tuesday, they don't.
I understand. I appreciate everyone's time.
Yes, thank you all very much. And like it said in the email, if any of you have expertise that you would like to share in a similar forum, or you know any other members who you think would be good candidates to do something like this, you know, we're really looking to showcase the expertise of this great group of members that we have here in the Buffalo Niagara chapter. So please don't hesitate to reach out to me, reach out to anyone that you know on the board who can communicate this to us, because we'd really like to do many more of these to keep people connected, since we can't do so much in person. So thanks again to you, Heidi. Thanks again to everyone for being here and participating, and we hope to see you soon. Take care.
Thank you.